Good afternoon, everyone. It's a very interesting topic that we've got. And before I start, I feel lucky today because I don't have to answer questions. I only have to ask. So if you have any question related to diagnostics, Dr. Velumani is the person who's going to answer. So straight jumping into the topic, it's a very interesting topic, close to my heart. I worked for many years with Hindustan Lever marketing department addressing consumers. What the core proposition is, advertising, communication. And I think that's a question which has been posed on this panel. Before I get deeper into a customer-centric model, I have a sort of an issue in answering this question, who's the customer in healthcare. So I think I'll put this question to all the panelists. Maybe one by one, if you can address, who is the real customer in healthcare? Because when I sit as the CEO of my own company, I actually get complaints not from the patients, but I get from a lot of other people in his or her ecosystem. So I actually don't know who the customer in healthcare is. So let's ask this question to all these people on the panel. Let me start with Dr. Velumani first. What do you think, who is the customer in healthcare?
Customer in healthcare is always the man who has the pain and the suffering. The money comes out from his pocket only. In between, we have a medical doctor who moderates between the actual client and the service providers. So only 1% of the customer actually can talk, but I think the doctor is considered to be a customer by the laboratories, but truly he is not the consumer of the services. So there is a pseudo system inside where you can't directly interact medically with an end user all the time.
So according to you, the customer who pays is the customer?
I think the man who consumes pays and the man who pays is the consumer and the consumer is the customer.
So do you think in future when the insurance penetration goes up, the insurance companies will become the customer in healthcare?
Everybody, I think, be it any industry, the consumer is the customer, not the distributor, not the facilitator, not the aggregator. The customer remains always the man who has the pain and he has come to solve his issues.
Great. So Dr. Desai, what's your view on this?
Yeah, so I would tend to agree with him that, the end customer actually is the patient. Okay. Now, in India, you need to probably look at it differently than what you would see in other countries because we are predominantly an economy which is, lives in two Indias. They call one is India, the other is Bharat. And both the customers will need different kind of, solutions which will be there. Some of it, since it's a buying power, which drives the customer, so insurance surely in future, is going to be a customer to the, industry per se, and government probably has realized that even in the Bharat part of India, they are going to put money in hand of this customer and allow him to choose. So at the end of the day, it's going to be the patient who is the customer with the power to buy.
I think I agree. Most of my experience has mostly been with middle to bottom of the pyramid kind of people. And even there, I think, unless the provider is really able to satisfy their needs and outcomes, they'll also go looking. So even if the insurance is paying, and a significant portion of the population I deal with is covered by social insurance, which is the government. And while the government or other players do put demands on the providers, ultimately I think the consumer makes the choice based on outcomes and the capability that we are offering. So I think our focus as providers are always going to remain on whether we are able to provide the best outcomes and the best results for these people, irrespective. I think the second entity for, in our case, we run a healthcare organization. I think doctors tend to be quite a bit of internal customers who need to be managed, for sure.
I think from a banker perspective, if you ask, the way we look at it, the way we look at the healthcare play, I mean, I would agree with the fellow panelists, the ultimate patient or the patient remains the ultimate customer for any healthcare play. But I think with each of the plays have different stakeholders, and they all become the customer to that, to that play. So, to give an example, for a pharma company, ultimately it's the patient who's consuming the medicines, but doctor also plays a very critical role in, what medicine is to be prescribed. So he becomes a very key stakeholder and a customer for the pharma company. For a healthcare play, again, doctor plays the same role, but ultimately it's the patient who's paying the final check, as Dr. Velumani mentioned. He remains the key customer. So across, from a customer-centric, the point that the question is, the patient who's ultimately, under the pain or, consuming the medicine, etc., remains the
Great.
customer as such.
So we're all talking about patient in the center of the business, right? Yeah. In the last 11 years I've been here in this industry, I've seen that the models actually have been changing from being a transaction-oriented to engagement model. So with the rise of non-communicable diseases going up, and I see the same patient coming over and over again for the same test. So it's somewhat akin to a consumer product where it's like fast-moving tests we do. So Dr. Velumani, your views on this, is the model changing from a transaction to an engagement model that I'm seeing the same patient over and over again during a purchase cycle? Do you see that changing?
Yeah, it's changing and it's rapidly changing. So much so even the players find it difficult to adapt to. A few decades back, I don't think anybody went to do or meet a doctor or do a test until he had a pain or a fever or a swelling. Today, people are conscious and people are going ahead and meeting doctors voluntarily even before the pain starts. So if you ask me, 20 years back, India had only 1% preventive care. Today, India has roughly around 10% preventive care. Only when India crosses 50% preventive care, we can call ourselves as a developed market. Very rapidly changing. Diseases only were attended till 20 years back. Today, people are recognizing disorders much early. Acute illnesses only were attended. Today, chronic illnesses are getting an attention. So if you look at it, the marketplace is changing depending upon the needs of the customer. Then the laboratories are also changing. What are they looking at? Volume and value. Volume comes from some segment, value comes from some other segment. So they are also adapting models, B2B or B2C, depending upon where volume is and where value is. If you ask me to sum it up in 3 minutes, this is 30 years of journey. It's very difficult to sum it up, but the way in which the 4 top players becoming taller, many players becoming organized, this industry is undergoing a very rapid change, and I am not surprised about the valuation multiples me or the Om have got. That always says that there is too much ahead in the couple of decades in this specific industry to see changes, values, and prosperity.
Thank you. So, Dr. Desai, I have a question for you. Last week I was in the US, I picked up a very nice magazine about the way healthcare is changing in developed countries. A very interesting things it talks about. It actually visualizes 21st century hospitals as virtual clinics. It also says hospitals without beds. It also says that this entire mobile medicine is going to take over. It also says that beds will actually move into homes of people. So you consult a lot of hospitals. Do you see that happening soon, or is it a pie in the sky?
I guess you read that in the US?
Yes.
All right. So like I said, we're still struggling with the Bharat part of it. So it's going to take us some time. But I would like to take upon from where Chintan left, that this big format general hospital, I think in India, this will continue for a while, because we still not reached the era of speciality where we can deconstruct it out of the hospital. Except for what he rightly pointed out, I would just add to it that whatever is repetitive probably can come out. So it's like dialysis, it's like chemotherapy, it's like radiotherapy. But the bulk of these specialties also will remain within the hospital. That is number one. Number two, for whatever we say, healthcare as compared to any other service industry, there is an interplay between the caregiver and the patient. So there would be maybe about 40%, or maybe even 50% probably technology can replace. Okay. At the end of the day, even if 80% of a knee replacement is based on technology, there is a 20% which the skill of the doctor. Same goes in terms of eye, where it's retina, you still need the doctor to come in. So I think we cannot probably take it out completely. And for someone like us in India, where the volume is so high, to reach that virtual level of healthcare is going to be difficult. Even we have seen that telemedicine has not taken, the kind of route that one would like it to reach it, to hinterland India. Having said that, there have been models which are coming up. But one thing which is, quite surprising, and I don't know why, maybe, you guys could think about that, is none of these chains, except maybe Apollo to a certain extent, has gone and dabbled into this, smaller things. What I'm saying is repetitive business coming out and then getting service. So you need a hub, which is that 1600 bedder, and then if you could create those spokes, none of them actually have done that. I don't know why, Diagnostics probably, is a easier way of doing it because it's mostly technology. Interface with, human skill is less, except for histopathology, probably. Some other things like, home healthcare, I think that probably should be encouraged more, and I think these companies would probably do much better. There are still nuts and bolts, it's still early stages. There are a lot of digital healthcare, which you are probably seeing now, which actually is an enabler. So if you look at an hospital, there is a pre-hospital, pre-admission processes, which this digital technologies probably can do. The hospital per se, I think, would get smarter. I mean, it would be in terms of the room layouts, in terms of how medical records get handled and then, transmitted to the doctor for a quicker kind of thing. But beyond that, hospitals probably will not change. There is more technology, that's all. But then there is another which is post-admission, post-discharge, whatever is the business point. I think there will be a tremendous amount of growth, and it is required also. That's one of the ways how, Western world has reduced the cost of, the care which is inpatient by reducing the ALOS. So that kind of thing, I think that those two businesses, I'm saying the pre-admission and the post-admission probably is where there will be more growth, in my view.
Okay, great. So you still feel that many of these ideas are ahead of time. So Kiran, I'll come back to you. I have a question related to that to Prashant. Prashant, let's look at a customer-centric approach, which is about patient. And many of these conferences I attend, that first chart that I see is the big issue is accessibility, big issue is affordability, and the quality of healthcare. I think quality part, let me not ask that question, but the real issue for India is accessibility. Many parts of India, we don't have access to healthcare. And wherever access is there, it's very expensive. Now, one side I see that technology probably will take little time. And I also see that everybody raising a question of scalability. And I strongly believe, having got a lot of experience in healthcare, many of these models are not able to scale up because the person who delivers the healthcare is your most expensive resource. Unlike diagnostics, we are lucky enough because the front-ending part is not that expensive, which is the guy who collects the blood sample. And we are able to scale up faster. It's asset-light, ROC is better. But when you go to any other specialty or hospital, the guy who is interfacing with the patient is the most expensive person. On the other side, we see that the technology probably can answer that, can solve that problem. Why is that industry not taking up this whole technology piece in a big way and addressing accessibility and affordability?
I think I'll probably link this answer to what Dr. Desai was alluding to, and your question was in terms of 21st century model or how the hospitals are evolving. I think the way I look at it is that the entire hospital model is actually getting unraveled. You have services which are not complex or high-end, as Dr. Desai mentioned, probably repetitive, being taken out. And that probably addresses the question of the scalability. You have, the earlier sessions talked a lot about the mother and child care, which is a service which can easily be taken out of the hospital. You have orthopedic services which can be taken out of the hospital. You have dialysis which are being managed by the likes of Nephroplus, etc., other players. Right? Each of these services are scalable. These are low capex models, can be easily taken out of the hospital ecosystem, in neighborhoods, etc. So that, addresses the scalability point of view, and whether these models can then be taken from the tier 1 models, tier 1 cities into tier 2, tier 3 cities, something which, the diagnostics labs have been able to replicate very easily. But minute you bring down the capex angle of, the healthcare delivery, you would see the scaling up of the models. You will start taking these models into tier 2, tier 3 cities. Right now what we are seeing is the question that you asked in terms of the delivery which is being made, the high cost, the doctor, etc., who's the last mile delivery person, and he is very high cost. Minute you take it from, and they are all moving towards the cities, minute you take it down to the tier 2, tier 3 level, the cost comes down of these doctors, the delivery, the entire delivery model changes. So taking it out from the hospitals, breaking down the services and taking it to tier 2, tier 3 cities will ultimately address the scalability question, at the same time address the affordability question as well. So I'm not too sure if I answered that question, but I think that's the way I look at it.
Thank you. Kiran, you do very interesting stuff, which is about especially middle and the bottom pyramid, and also your own journey from technology and IT and has gone into healthcare. I want to ask questions related to that, but the question that I have for you is on this eye care as a single specialty. To my mind, if you want to be customer-centric, it has to be all under one roof. I've always believed that if I walk into one facility, right from beginning as a payer, any other help I require, it should be all under one roof. But I see that models which are now moving for single specialty versus multi-specialty. I'm a little confused as to which one is customer-centric.
I think a lot of the debate in the morning has also been about this whole single specialty versus multi-specialty. There's absolutely truth in your point that if the patient does not know what his condition is, or let's say many of the patients I deal with are also not very highly educated, where they can say, oh, okay, I need to see doctor, specialist X or specialist Y. So the real question you're asking is, who's going to make the determination for them and who's going to guide them, and then is the institution where they arrived for care going to be able to cater to their needs? I mean, the reality of the markets I operate in is there are no specialists available. In most of the cases where we have currently set up, we are probably one of the very few, or the first eye hospital or the ophthalmologist. And if you start looking from a width standpoint, right, I've been very interested in seeing what is the width gap. And I see the same thing, the same town does not have dermatologists, does not have ENT guys, does not have, usually the first two specialties I see which arrive there is gynecology, followed by orthopedics, and the small town community. There's a whole bunch of general practitioners, many of them practicing allopathy, but not necessarily qualified for allopathy, right? So it's a very complex situation. So I think while the customer need may be exactly what you say it is, which is that there needs to be a single point where he can offer it, I don't think on the delivery side, at least in the current tier 2, tier 3, or at least tier 2 going downwards, just the skill does not exist to deliver on that expectation, right? Now, can technology, and I think the point that he was making, I think more and more as I meet doctors, as we try to scale, one of the key challenges we have is bringing doctors on board. Most of my conversations tend to be with the doctor, his wife, because the infrastructure in some of these towns, they're worried about, will my children get educated in this kind of a place, right? And why should I not live in the larger tier 1 cities? And why should I go work in a tier 2 city? And you can offer whatever comp you want, but those expectations that they have for their own lifestyle always come in. So one thesis I do have is that this whole 21st century technology bit that we are talking about hospitals of the future is probably an answer for Bharat, right? But while in diagnostics, machines, a blood draw and a machine, you can still get away, but who's communicating the result still is a qualified or an expensive resource, right? And the touch that you need in healthcare is unfortunately still a challenge. So until I think consumers reach the point where they accept the delivery of that through technology. I think the ability for, even though the technologies may evolve, I think the ability for the technologies to be used in the lower line is always going to be difficult. I think we have very quickly come to the point where we shop now on a mobile phone and we're okay with it. Whether we're willing to accept medical care through a similar device is going to be a key question on the consumer side.
Interesting points. So, Dr. Velumani, there are many models which are in diagnostics. There is a centralized lab model, there is a decentralized models like some of us have. Now, if you want to become a customer-centric, I also hear one model which most people are talking about is point-of-care testing. And this question I've been asked by most investors on the roadshows. If that becomes a reality, do you think there is a disruption waiting to happen in diagnostics which is going to be customer-centric point-of-care model?
Yeah, I also learnt only from roadshows. There are around 100 investors whom I have met, almost 90% of them asked, will this disrupt you? Let's look at diagnostics. It's not one test, two tests, hundreds of tests needed. And also the technology is not one and two. There are dozens of technologies. It's very difficult to make a device which addresses all technologies and gets closer to the patient bed and gives all solution. With all said and done, blood sugar only has been talked about last 20 years as a POCT in terms of diagnostics. And in diagnostics, POCT disrupting, I don't visualize. Investors must be thinking that I am talking positive, but I am fully aware. Another 20 years, there is nothing on the table to come to the floor and then to reach to the bed. So that is something which, unless somebody disrupts with the technology, where you don't just need to do any test, move the gadget around the body, it can display that disorder. I'm seeing 2050 potential, it's such a thing possible. Science is evolving fast, and today 8 billion population, almost 3 billion have computers in their hand, and all their brains are very positive. Things may work, but next 10, 15 years, I don't see truly a POCT disrupting. Having said that, the models are evolving. The centralized laboratories solve some purpose. The local laboratories solve some purpose. Some of them come for diseases. So you can't ask them to wait for 3 days. You have to address to them by the evening. So the local laboratories model will continue. The centralized laboratories are working on volume. They work as a back-end kitchen for hundreds of front-end restaurants in the entire country. And I'm sure the top 4 players, if they are too powerful today, in the esoteric tests, the volumes which they enjoy, they can afford to do a lot more simplifications, amplifications, and reach. So I think the model is going to be 70% tests will be done by local laboratories, 29% will be done by centralized laboratories, 1% will be done by POCT.
Still a hope for our models to come.
Yeah.
Right. Okay, great. So I have one last question before I throw it open for Q&A, and I want all of you to answer this. As we want to build consumer-centric or customer-centric model, I still believe that we are saying like this, but we are not doing it because there are so many healthcare players, diagnostics, pharma companies, single specialty, multi-specialty hospital, primary care, but the customer is still one, which is patient. And at every interaction, there is a lot of data being generated. And I know at my end, diagnostic, what is the data? But I don't think we are all talking to each other. There are linkages that are established. And a lot of these questions came up in the earlier panel as well, as what's the role of data and how we are putting it together. What do you think is going to happen in future to derive that data which is being generated and we create value? And who is going to do that? Is it diagnostic guy, or is it a hospital, or some neutral third party who's going to come and suddenly put it all together? So what are your views on the role of data and analytics in future to link it up all the stakeholders and provide value to the key customer? So maybe Dr. Desai, I want to start from you because you have a lot of experience in hospitals, and at least on this panel you represent all of them. So why don't you speak about this first?
So I think, let me go back to the first question you asked, that who really is the customer? And picking up from this question, I think there are three, entities which probably are the most important stakeholders in this whole business. One is the patient, of course, the customer, who makes a choice. In bigger cities, the choice is made by the individual patient. But in tier 2, tier 3, as we go down the rung, the choice is actually made by the doctor. That what should be done, how should be done, where should be done, is all demanded by the doctor. Patient has very little choice. He just has to follow the instruction which is going on. So that brings to the second important customer, who is the doctor. Now, when you scale up, scaling up, the easier part of scale up is creating the hard infrastructure. Probably, maybe Vasan is an example where the scale up was very rapid and was done very well. But where it starts to crumble is the soft infrastructure, which one part is the doctor. You heard him say that it actually is, difficult, and it's actually not cheaper to get a doctor in rural India. He actually demands more salary. If you go to a tier 2, tier 3 town, you want a cardiologist or a neurosurgeon or a transplant surgeon. If you are paying him X in Bombay, he will demand 2X. It's the other way. It's not cheaper, in terms of human resource. The capex more or less remains the same. So the second customer you need to, educate and enhance numbers is doctor, himself, because he is making choices which is going to be delivered by hospitals or diagnostics. The rapid growth of diagnostics is probably because this doctor is remote and is still able to, report. So that's the advantage of diagnostics as a business. You don't depend, not too much dependency on the clinician himself. The third most important, and from where probably the data will come and analytics, will play out, is the insurance. I think that's the single most important driver that is going to drive this in the country today. I mean, you had private insurance, most of them probably are now got their act together, and I don't know the numbers, but, maybe now the premium that they charge, they are able to make some money. I'm not very sure about it, but say 2, 3, 5 years ago, they were not making any money, they were spending more money than what they were collecting. And government, you see Andhra, you see Karnataka, you see, here we do consulting in Chhattisgarh, everywhere, the patient that even private hospitals are getting is through the insurance. And everything gets reported back to them, in terms of patient history, how the progression happened, how much was the cost, where money is going. So I think there, the analytics part of it probably will have to come through the insurance, and that, will drive decisions.
I actually have very strong views on this topic. So my belief is that while I think everybody accepts the value that a patient data would add to the overall healthcare ecosystem, the reality is there is no incentive for any player to generate it in good quality, do it in standards, or share it. Right? I mean, absolutely nothing today in the healthcare infrastructure that enables it. I think the real shift is only going to come from the government and an external structure of pressure. And I think it's likely to happen as the percentage of population that's covered by government starts going up. I mean, I think the government has fairly ambitious plan on what they want to cover over time. And hopefully, along with it, will come certain demand for certain quality standards as well as certain information standards that would need to be kind of shared. Now, whether that is ultimately done in a format which is a reasonable standard, but moment a significant portion of the paying population gets covered by one large player who can influence what the whole ecosystem has to kind of drive towards as a standard, it's unlikely that you're going to see, I think any amount of good data gathering in this country. The second piece I would argue is that the whole thesis that we say that doctors don't fill out or do something, right? In any scenario where there is a payment involved, like unless you will not receive this money unless you get this done, it happens. You don't have to worry about that piece in my mind.
So you see, as long as very fragmented, this will remain a bit of a challenge. Yeah. Okay, Prashant, your views on this?
I think the way, the data is getting generated by each of them. I mean, the labs are creating enough data, the pharma companies are creating enough data. I think the question that you initially asked, whether the data which is, or the, whether it will be harnessed by a third party or whether it will be harnessed by the individual company, I think the answer lies probably it's best done by a third party, The reason being is that if you have the data, you will analyze it only from your perspective. There is no marriage between the way you look at the data, the way a pharma company would look at that data, or way the government or the insurance companies would look at that data. I think, there are companies like, I was reading about this company called Healthy Billions, which essentially what they're trying to do is take the data from the labs, use the test data, identify at lab level, at the at geography level, what are the kind of tests which are being done. Through that, the pharma companies are able to harness that information and identify the micro markets where they need to particularly push a product, or how do they need to market a particular drug in a particular area. The governments in turn are can use the data to identify or predict, okay, this is the season when you have an outbreak of a particular disease. This is the steps that we need to take in terms of cleaning up of that area or whatever. Similarly, insurance company would be able to use the data to probably better manage their insurance rates, that, okay, maybe for this market, because there's a high prevalence of something, the insurance has to be something else. So it's best, the entire data, it's best utilized by a third party who can, analyze it from different perspectives, from different player perspective. And, the provider of the data can always, capitalize on it and make it another revenue stream for itself. So I look at it, from that perspective.
So good. So if we are fragmented, if one player can't do this, there's an answer here. A third party can come in and get the data from everyone and collate it.
I hope privacy is being taken care of. I mean, ultimately, I think the data belongs to the consumer.
Well, it's easier said than done. Yeah. So final word, Dr. Velumani, from you.
I am a bit negative on this data part. Datagiri has just now started according to newspapers. So we still haven't accumulated adequate data with fair amount of reliability to conclude that we have a data and we can use it. In fact, if you ask me, first there are alphabets, then there are words, then there are statements, then there are paragraphs, then there are chapters, and there is a story. We are still not in a word level in this so-called big analytics, which only says, if I am negative towards, until 2025, we are very rarely to get something, a story. The story will evolve when everything falls in place. So investing too much and right now and being aggressive will have its own limitation. This is my own perception in terms of the big analytics. When it comes to customer-centric, I think currently what is needed are only 5. Quality, cost, speed, reach, and systems. If these 5 are there, customer is the happiest man. Anything more we can add, he will be more happier. This is my perception.
Okay. Thank you. So we have about 10 minutes left, but what has come out of these discussion is that at the core of it, there's a patient, but there are other customers around that patient, which is payer, which is also a doctor. In fact, many years back, I had visited a hospital in Thailand, Bumrungrad, and I asked the CEO one simple question, who is your customer? And I was really surprised to get his answer. He actually told me that my customer is not my patient. My customer is actually the doctor who is working in the hospital. So doctor is also a very important customer in healthcare ecosystem. And as insurance grows in India, insurance will actually become another customer for us because they are the ones who are going to pay for, and I'm sure hospital people must be facing that challenge. Okay, on that note, thank you very much. We now, I think, break for lunch. Thank you. Thank you all.